Okay, so let's go ahead and get started. So this is the second of our two-part series on imaging of cardiomyopathies. And so last week, as you'll recall, we talked about the role of echocardiography, and we talked about the role of cardiac MRI in initial evaluation of cardiomyopathies. We're going to turn now today to talk about restrictive and inflammatory cardiomyopathies, and this is where I think from an imaging standpoint, we're going to touch on cardiac MRI as well as nuclear techniques. So as you recall from last week, I had kind of, there's multiple different classification schemes for cardiomyopathy. So this is just one that I came up with, which is to break it down to the genetic and the dilated, which we talked about last week. And then this week, we'll talk about the inflammatory and the restrictive. So, and again, to kind of backtrack to last week, I think an important premise to keep in mind is from the standpoint of cardiac MRI, one of the key things that we look at is not just the presence of myocardial damage, but rather the pattern, location, and extent. Because that really kind of helps you first to identify if you see an area of myocardial damage, whether it's ischemic or non-ischemic. And as you recall, we talked about last week that if you see an area of myocardial damage that involves the middle of the myocardium, as is shown in this left-hand example here, that involves the epicardium but spares the subendocardial layer, or that subendocardial but that's global and really doesn't fit a coronary artery distribution, these are all scenarios where we think of myocardial damage being from a non-ischemic etiology. And so one of the reasons that amongst non-ischemic cardiomyopathies, it's important to try to go beyond just simply saying, yes, there's no coronary disease, but to try to get an idea of what the underlying etiology is because we know from this publication over 20 years ago, all non-ischemics are not created equal, and there's a variable prognosis depending upon what the underlying etiology is. We also talked about last week is the fact that the myocardial scar substrate that we detect by MRI in non-ischemic cardiomyopathy can actually be important from the standpoint of risk stratification, specifically for arrhythmic risk, as well as for all-cause or heart failure mortality as well. So now let's start off with a case. So this is a 44-year-old Caucasian woman who has no past medical history. She comes to the emergency department complaining of 2 episodes of syncope within the past week. She notes progressive fatigue and dyspnea, which has been going on for about 6 months. Denies any chest pain, PND, or palpitations. And on exam, her blood pressure is 103/50. Heart rate is 43, but regular. And physical exam is reported as normal. So a 12-lead electrocardiogram was obtained, and I want one of the fellows here to Priyanka, you just came in the room, so we'll put you right on the spot. What do you think of this EKG? Okay, so everyone see that? If you look, I had a slide where I showed it marching out, but you can see that there's P waves, but the P waves are actually going at a completely separate from the QRS complexes, right? And the QRS complex is much, much slower than what the P wave rate is. And so this person has complete heart block. So the P waves are marching at their own pace, the QRSs are not following along, and they're marching at their own pace, but at a much slower pace, likely due to an escape rhythm, and you've got a wide or widened QRS complex. So here's the echocardiogram. So maybe we'll go to one of the second-year fellows. Anybody want to tell me what they see on this echo? Because this patient, based on this EKG, got hospitalized, underwent an echocardiogram. What do you see? Okay. Okay. So overall LV function looks good. Now, and you think the LV is dilated here, or? Yeah. But So maybe a little bit borderline, right? Okay. But overall ejection fraction is normal. You're concerned about a little bit of thickening of the basal septum. But on the basis of this, again, I think it's relatively nonspecific. There's no kind of major glaring abnormalities that you see on the echocardiogram. This patient was actually transferred here from an outside hospital because they wanted to, and we'll tell you the story in a second, but they wanted to get a cardiac MRI before doing a definitive treatment option for this patient. So one of the third-year fellows, if there's any third-year fellows, what do you see on the MRI scan? Third year? HJ. Yeah. What do you see on this cardiac MRI scan?
Well, I think that there's a bit of septal maybe a bit of morning.
Okay, so a couple of things I'll point out. So one is, yes, the basal septum looks like there's increased thickness. Overall LV function looks preserved, right? What do you think about the RV?
It looks to be pretty normal cardiac function.
Okay. And what about RV wall thickness?
Oh, yes, there is some RV.
Yeah. But no, what's interesting is it's really kind of confined to this basal segment, right? Segment of the RV. The apical and mid segments of RV look relatively normal thickness. So we'll come back to this in a second. But there's a few abnormalities here. But again, you know, looking at this, you're not going to say there's clearly a wall motion abnormality. Overall ejection fraction looks preserved. But there's a couple areas where there's abnormally increased wall thickness in a few areas. Okay? So now here's a delayed enhancement MRI. Now maybe the first year MRI fellows, somebody want to take this? Was that Amr? Go ahead. Speak. Oh, yeah, grab the microphone.
So there is dense, almost transmural scar in the hypertrophied septum. So this is in the lateral wall.
Okay.
And also in the septum. Yeah,
Okay.
that's it.
And then
I
what
don't
about
see it in
what
the
about this
RV
area
or-
in the RV?
And in the RV as well, yeah.
Yeah, so actually, if you look at it now in retrospect, there's actually three areas where there's kind of focally increased wall thickness. There's the basal septum, and you see evidence of LGE in that area. What about the lateral wall? If you look now, you can see also the lateral wall, the apical lateral wall also looks focally thickened, and you see LGE in this area. And then this area where we saw increased wall thickness in the right ventricle, you also see an area of hyperenhancement in that area as well. So you've got really, you know, when you look at all of this together, especially with the aid of the contrast, you can see that there's multiple areas of abnormality affecting the septum, the lateral wall, as well as the right ventricle. A few things, and again, we tend to use the term, if we see increased wall thickness, to say hypertrophy. Technically, it's better just to say increased wall thickness, because in this case, this is likely not due to myocyte hypertrophy, but in fact, as you can see, that there's areas of gadolinium uptake, and as I'll show you on the next set of images, if you do this T2 weighted imaging, you can actually see there's increased signal suggesting increased water content. So this is an area of acute injury to this area. And obviously this would not fit a coronary artery distribution, so this looks like an area, like a scenario where you've got acute myocardial injury or myocardial damage from some process that's affecting the septum, the lateral wall, and the RV. So when you think about this, already some things should come to your mind. I'm going to make it even easier for you because I'm going to show you one additional set of images. For those of you that have done MRI or CT rotations, it shouldn't be too hard to see what we're talking about here. Now, so MRI is not going to specifically tell you calcification, but I think what you're talking about is when you look at these lymph nodes here, you see significant lymphadenopathy, right? So put this all together, what's the most likely diagnosis? So you've got a patient who comes in with syncope, who comes in with heart block, who's got multiple areas in the septum, lateral wall, RV of focally increased wall thickness with myocardial LGE. Diagnosis is what? Yeah, sarcoid would be the thing that you'd be concerned about. All right, and so, and in fact, based on these findings, that's exactly what we said. And this person, the scenario was this person was going to get a pacemaker, but the electrophysiologist said, well, I want to get a look at the myocardium first, because obviously in a young person who's developed heart block, the concern would be for some kind of a myocardial process. And this person actually went on to get biopsy, which also showed findings consistent with cardiac sarcoid. So let me just kind of walk you through what's the literature with regard to MRI in sarcoid. So one of the things is obviously the pattern of myocardial damage that you can see in sarcoid. And this is kind of one of the classic publications back in circulation in 2009, which really showed that with sarcoid, you can get a variety of different presentations. You can get subendocardial, transmural, mid-myocardial, epicardial, and oftentimes multiple foci. And in this particular study, they found that the prevalence of myocardial damage in patients who had known extracardiac sarcoid was almost 25%, compared to using the traditional Japanese Ministry of Health criteria, where the prevalence of abnormalities was only identified at about 10 to 12%, suggesting that the MRI is more sensitive at being able to identify myocardial involvement. Now, a few things from this initial study pointed out were, one, it's oftentimes multifocal when there's sarcoid involvement. It can be transmural, and the RV free wall may be affected as well. This is a very nice kind of interesting study by somebody out of the University of Minnesota, where they actually did a meta-analysis of all the published literature of patients with sarcoidosis where there's autopsy, where there's pictures of the autopsy heart, and they went through and said, okay, let's look at where the locations of the myocardial damage is based on autopsy. And what they found in greater than 90% of cases, it was subepicardial, so basically sparing the endocardial layer, multifocal in the LV, typically involved the interventricular septum, and frequently involved the right ventricular free wall. Now, obviously, though, these are autopsy studies, so these are patients that died with sarcoidosis. So one of the questions that came up was, what about in living human patients? And so this group followed up with a series of about 500 patients that was just published late last year in JAMA Cardiology, where they actually went through and characterized patients who had biopsy-confirmed sarcoidosis, either extracardiac or intracardiac, and they looked at the myocardial abnormalities, and they categorized these patients into a few different groups. Those with normal LV function and no LGE, those with impaired LV function but with no evidence of late gadolinium enhancement, those with the kind of a non-specific pattern of LGE in the myocardium. So in other words, not the findings that you typically see on pathology where, again, septal, multifocal, involving both the LV or the RV, but rather just kind of a non-specific area of LGE. And then those patients who had kind of the classic findings that they saw in pathology that we talked about. So subepicardial, multifocal, septal, RV free wall. And then they follow these patients out over time. And if you look at arrhythmic events, what you'll notice, it's really only those patients who have those classic findings that you would see on pathology, when you see those by MRI, that those are the patients that have a high event rate. Whereas the patients who had just an impairment in LV function, who had non-specific patterns of LGE, or had no LGE and normal LV function, their event rate was quite low. Now, if you look at all, heart failure endpoints, obviously, that's where you see that LV dysfunction or the presence of any LGE leads to an increase in the incidence of heart failure endpoints. Then obviously the combination of the classic sarcoid findings by MRI led to a much higher incidence of heart failure endpoints. That was a single center experience. Here is now kind of a recently published meta-analysis which looked at 13 studies of patients with known or suspected cardiac sarcoidosis, 1,300 patients with about 3.1 years of mean follow-up. And what you find really is that for patients with known or suspected sarcoidosis, if there's evidence of LGE indicating that there's myocardial abnormalities, then the prognosis is much worse. But on the flip side, if there's no evidence of LGE, then the prognosis in these patients is actually quite good. And the incidence of ventricular arrhythmic events was actually quite low. So let me skip forward in the interest of time then and talk about what is kind of our Heart Rhythm Society expert consensus statement on how we should approach these patients and how do we see these patients in the lab. And I think there's two pathways you need to think about. There's those patients who have known sarcoidosis involving some extracardiac organ. And in those cases then, if you see evidence of myocardial abnormalities on MRI, I think that makes a very high likelihood that there's cardiac involvement. On the flip side, I think they stress the importance of having some histologic diagnosis of sarcoidosis, whether it's in the tissue or whether it's extracardiac, and then you find some evidence of cardiac involvement. So I think the key things to always remember is you want to try to make a diagnosis first, then look for cardiac involvement, right? And so there may be cases where cardiac involvement may trigger you to search for sarcoidosis. And so here's kind of a nice schematic which I put together, which says if you have people who have known extracardiac sarcoid, again, the guidelines don't recommend all of these patients should get screening, but the criteria that recommend that they should get screening for cardiac involvement is if there's symptoms, and they define as palpitations, pre-syncope or syncope, if there's an abnormal EKG or an abnormal echocardiogram, and then obviously then you're doing your advanced imaging to try to identify cardiac involvement. On the flip side, if you have patients that don't have a known history of sarcoidosis, then I think the things that clue you into the potential will be unexplained high-grade block, AV block, in patients under the age of 60. And so this is an example of the patient that we saw today was in their 40s who comes in with complete heart block. The other example where you think about sarcoid would be patients with VT of unknown etiology or patients who have heart failure. And in those cases then, the imaging can help you to raise the possibility of sarcoid as a potential diagnosis and then also to look for and identify cardiac involvement. Yes?
Is it any heart failure or unexplained heart failure?
Well, so yes, I mean technically where you think about sarcoidosis would be in the sense of unexplained heart failure. I left it as a little bit broader because if you look at kind of what the current guidelines talk about and what we talked about for these last two lectures, the role of MRI probably extends to really most heart failure because whether it's ischemic or non-ischemic, oftentimes there's incremental information that you can get. And I'll show what the ACC appropriate use criteria shows at the end. And so here's what, this was kind of a proposed algorithm from the Brigham group, which is to say if you have patients with known or suspected cardiac sarcoid, and if your MRI then is positive, showing again, not just any nonspecific pattern, but a more characteristic pattern, consider ICD placement. On the flip side, if you have no evidence of LGE, then this is where there's still some, or the CMR is inconclusive. Maybe in that case there's a role for PET. I think there's probably still, that's something that could be discussed and debated. And I think that then if there is evidence of FDG uptake, so if you have clearly evidence of or high suspicion for cardiac sarcoid, then I think looking for the presence of FDG uptake to identify acute inflammation as opposed to chronic myocardial scar could be important because then you can tailor immunosuppressive therapy. And I think Mouaz will touch on this later. But I think, again, the couple of key things I want to point out. One, when you see increased wall thickness, doesn't always mean hypertrophy. When you see an area of LGE, it doesn't necessarily mean scar, right? Because you can have LGE in the acute setting as well as in the chronic setting. Yep. But it means myocardial damage, right? Yes. Victor.
For secondary prevention, or if they've had any history of VTs, or everyone just gets an ICD?
Right. So obviously, again, if you look at the, I think from the standpoint of the imaging perspective, it should at least consider, right? As far as what the specific criteria are for when you would place it, it wouldn't necessarily just be secondary prevention. There is a role for even before the patients had a overt, significant arrhythmic event. If they're having evidence of ventricular arrhythmias, that there may be a role for prophylactic ICD placement in these patients with sarcoid, because again, the arrhythmic risk for these patients is low. But again, I think where this algorithm doesn't say definitely place an ICD, it says consider it. From a general cardiologist or imaging standpoint, what this should clue you in to say I need to get an electrophysiologist input regarding arrhythmic risk for this patient. Right.
So how often do we see negative late gadolinium enhancement get positive? Is it something,
Yeah, positive what, sorry?
how often do we see more scar?
Yes.
Do we not see late gadolinium enhancement effectively becoming?
Yeah, so that's a great question, and I think,
We have two cases out of
Yeah. yeah, I think most, again, this is an area that's still emerging, but I think most people would say that it will be, if you have a good quality LGE imaging and that's completely normal, then it's very unlikely that there could be any abnormality. Okay, let's move on to another condition. This is another inflammatory condition, systemic lupus. And this is just a small series out of the UK or of Europe, where they looked at the abnormalities that you might find on cardiac MRI in patients with systemic lupus. And I think the key findings were, one, you could have evidence of myocardial late gadolinium enhancement in some of these patients. And in addition to that, oftentimes it can affect the pericardium, where it can lead to a thickening of the pericardium. And also, importantly, when you give gadolinium contrast, you can see areas of hyperenhancement of the pericardium, which is a sign of active pericardial inflammation. Now, let's move on to another scenario. So here's a case. And again, I'd like to have one of the first or second year fellows tell me what they see here. Grab the microphone too, please. Tell me what you see. Who wants to take this? So again, if you've done the echo lab rotation, these are just cine MRIs, so you can read these too.
So it looks like, looking at the LV, there's pretty significant hypertrophy. It's concentric pretty much everywhere. So to me, it's already smelling like an infiltrative process.
Okay. And so again, I'll go back to that statement I was making earlier. Let's call it increased wall thickness for now, right? We don't know necessarily that it's hypertrophy, but increased wall thickness, it looks concentric for the LV. What about the RV?
The RV, yeah, not so much, but maybe I'd say some increased thickness.
Yeah, so, and again, usually a normal RV wall thickness is about 4 millimeters. So this actually looks, this I think we measured about 5 or 6 millimeters. So the RV here also looks like it's increased wall thickness. What do you think about LV function?
Maybe mildly reduced.
Yeah, this is not a 20% EF. This I think we measured in the mid to high 40s, right? So there's mild LV dysfunction, RV dysfunction as well, increased wall thickness. There's pericardial fusion, and again, you're concerned about an infiltrative. Obviously, I think, but I'm sure in the echo lab or in the MRI lab, you could see many cases like this where it turns out not to be infiltrative, right? And so again, because the morphologic features alone are nonspecific. Now, if I show you post-contrast, maybe I'll let you take this again because this is an easy one. What do you see now? Describe what you see.
Yeah, I mean, so it looks like diffuse uptake through all over the LV.
Right. So not just the LV. What about the RV?
RV as well.
Yeah, the RV shows diffuse uptake. And if you look here, the atrial walls, right, also show contrast uptake as well. So really, here you have a diffuse pattern. And again, this is the classic finding that you see with cardiac amyloid involvement. And again, how do we see these patients? There's some patients that have known extracardiac amyloid. They get referred to imaging to identify is there cardiac involvement. And oftentimes, though, there's people that don't have known amyloid. They may just have increased wall thickness on imaging, on an echo, but it may be a patient who has hypertension or something. And the question then is, imaging then clues you into the possibility of the diagnosis of amyloid. And obviously, there's studies, both single center as well as multi-center, that show, this was a study looking at patients with known extracardiac amyloid, that if you have any evidence of hyperenhancement, again, using the MRI to identify cardiac involvement, the prognosis for these patients is much worse than for those patients who have no evidence of hyperenhancement. And again, this is just a meta-analysis from the literature showing, in fact, a 5-fold higher risk of adverse outcome, all-cause mortality, in patients with known extracardiac amyloid if there is cardiac involvement based on having delayed enhancement MRI by CMR. Now, one of the questions somebody may ask is, okay, so, last week we talked about scar. Now we're talking about sarcoid, we're talking about amyloid, all showing abnormalities in the myocardium with late gadolinium enhancement. And again, I think the unifying mechanism by which we see hyperenhancement really has to do not so much with, you're not imaging scar, Rather, what you're imaging is you're imaging expansion of the extracellular space. And that extracellular space expansion can occur in acute MI. It can occur in chronic scar, where you have a loose collagen matrix, but there's a lot of extracellular space. It can occur in acute non-ischemic injury, like acute sarcoid, where again, you've got now myocyte necrosis, and you've got edema and inflammation in that region. And it can also occur in conditions like amyloidosis or infiltrative cardiomyopathy, where you have protein deposition between the myocytes. In all of these scenarios, you can see it leads to an expansion of the space between myocytes, and that's where the gadolinium goes. Gadolinium goes to the extracellular space, and as a result, there's increased gadolinium, and therefore you see hyperenhancement. Okay, here's another case. Now, this is a young patient, 29 years old, African-American woman. She gets admitted with pneumonia, and she has some retrosternal chest pain. Her cardiac enzymes show a peak troponin of 2.67. Okay, this is not the high sensitivity assay. This is the assay we used to use 4 or 5 years ago. So there's definitely some myocardial necrosis that's occurred. Do we have one of the fellows that wants to tell me what they see here? Okay, let's get the microphone, Isa.
So I see the EF it looks overall hyperdynamic, but the percentage-wise, like the walls look hyperdynamic, but if we think about the EF itself, you see some regional wall motion abnormalities. Mostly I see in the four-chamber view towards the apex, infralateral, and potentially the apex as well, but it's hard to see in there.
Okay. And the other thing, what do you think about wall thickness?
So the basal infralateral looks a little more, no, I'm sorry. Interlateral and interoseptal are more thick. I was looking at that.
Yeah, exactly. So you've got kind of a regional increase in wall thickness here in the anterior anterolateral wall, right? You guys see this? Look at the inferior and lateral walls, especially in diastole. You've got an area of increased thickness, right? And again, does this tell you, based on this, does it tell you anything other than there's increased wall thickness there? It doesn't necessarily clue you into a diagnosis, right? Okay, now I'm going to show you the delayed enhancement MRI. And again, this is maybe for the MRI fellows. Some of this is also pattern recognition. What do you see? Describe the pattern, and then we'll talk about what this suggests. So one of the MRI fellows want to take this? Yeah, Hussam?
Yeah, so there's it seems like there's an area of LGE, but within that area, there's area of non-enhancement, the area in black.
Right. So you guys see this? So there's an area of the absence, there's black, right? Black signal, but then there's an area of high signal all the way around it, right? You can see that. So you've almost got kind of a multi-layered appearance, right? You've got normal myocardium here in the epicardium. You've got an area of hyperenhancement. You've got an area of hypoenhancement. And then there's a kind of another probably thin rim of hyperenhancement on the very subendocardial border here. This pattern, if you see this with this kind of regional location, does it make you think about anything? Okay, so it could be microvascular obstruction, although there you would expect to see that occurs in the setting of an acute infarct, right? And that should fit a coronary artery distribution. Is there a specific coronary distribution that could give you this pattern that you're seeing here? So is there anything else? And this is a little bit of kind of, was that? Yeah, and so, but not just kind of garden variety myocarditis. Let me maybe show you some lab work. White blood cell count and the eosinophils. So oftentimes you think about it affecting the apical or the inferior, but it can affect other areas as well, right? It's not specific predilection to one area. We've got other cases that affect different locations. This one I just pulled up happened to affect the anterior wall. This person actually has hypereosinophilic syndrome, okay? And again, this is where sometimes it's just a pattern that you see, but you got to put that in the context of also the clinical and other biomarker evidence that you have. This person actually got treated with steroids and anticoagulation. Follow-up imaging 3 months later, you can see that that increased wall thickness has actually gone away. Wall thickness is normalized. And when we do our delayed enhancement MRI, that area that you saw of the hypoenhancement has also gone away as well. that kind of thrombotic milieu has resolved now. Let me just wrap up in the interest of time. Hemochromatosis, this is another area where I think MRI is useful. This doesn't even really require contrast administration. You're simply using a specialized technique to look for the rate of T2 star decay. Things that lead to T2 star decay, one of them is increased iron content, which causes inhomogeneity in the magnetic field. And this is just showing an example of how using this technique where, again, doesn't require contrast administration, you can actually try to quantify what the myocardial T2 star is. And there's numerous studies showing that myocardial T2 star of less than 10 milliseconds is associated with a high likelihood of adverse events, specifically of heart failure events over the follow-up time period. So let me skip forward here in the interest of time and just show this example case here where there's kind of a nonspecific pattern of LGE that you see in the basal septum. This is one of the patterns that's been described in Anderson-Fabry disease. One of the things that you can do now with more newer imaging techniques is to try to actually look at the myocardial T1 time, because again, with Anderson-Fabry disease, you may expect to see that there's a decrease in the T1 time of the myocardium. But really to kind of come back to this schematic, which I started off this series of 2 lectures with, I think is you want to look at not just that there is myocardial damage, but really the pattern of the damage to try to be able to give you some clues as to what the underlying etiology is. And we know that ischemic myocardial injury tends to occur in the subendocardial or transmural locations, whereas non-ischemic can be this mid-wall, can be epicardial, can be kind of patchy foci at the RV insertion site, or it can give you this kind of global pattern. But again, look at the pattern, and that doesn't necessarily give you a definite diagnosis, but it clues you in to potential etiologies that it could be, and it clues you in that this is a non-ischemic pattern. And this, again, is the appropriate use criteria from 2019, showing what's the role of MRI in evaluation of patients, whether it's systolic dysfunction, whether it's pulmonary hypertension, to look at the myocardium, or to look at the heart structures. Excluding CAD in heart failure patients, there's a variety of indications where I think cardiac MRI is indicated. And lastly, I think the real strength of MRI, as we talked about, is this tissue characterization, the ability to look directly into the myocardium, which I think really helps you with diagnosis as well as prognosis, but I think ultimately will help us in the future, I think, hopefully, with therapeutic management of our patients. So with that, I want to thank you for your attention. I'm going to turn it over to Dr. Al-Mallah, who's going to talk to us about the role of nuclear.
So, cardiac MRI, as you just heard, is a great tool for assessment of cardiomyopathy. So, I'm going to show you a couple of instances where nuclear could complement the information that you get from cardiac MRI. And this field, this whole field of nuclear cardiology and cardiomyopathy was not there when I was in training. That was not too long ago. So this is a field that completely developed in the past less than 10 years. And we're still learning and it's an evolving field on this. So Dipan just spoke about cardiac sarcoid, and I completely agree with all the comments that made about the role of cardiac MRI. So we're not going to come to PET until you have an established diagnosis that there is something wrong. So what we recommend always is that we need to know that the MRI is done and we know that there is an abnormality. Now, once we make that diagnosis, we want to know, when you see this scar, you want to know if this scar is active inflammation or this is someone who had a scar, had inflammation many years ago, and now he's just had the sequelae of that inflammation, which is the scar, but it is not active. So with MRI, there are some tools that you can do that, but with PET, I think we have higher sensitivity to achieve that in terms of assessment of active inflammation versus old scarring. So first of all, the protocol that is done here is very different, because when I was standing on this podium a few weeks ago, I was telling you about viability, and I was telling you we want the myocytes to take the FDG that we give. Now we don't want the myocytes to take the FDG. So those of you who ate has insulin level high, so their myocytes are taking their glucose. Those like me who didn't eat yet have their insulin plummeted down, so now you don't have insulin in your body, so my myocytes are using free fatty acid. If I prolong it, all the myocytes are just going to use free fatty acid. So that's exactly what we do. The myocytes love free fatty acids, so we want to give them as much as free fatty acid as we do. So we tell them 1 day before or 2 days before, just no carbohydrates. We tell them that you just need to eat high-fat diet, and sorry for the prevention, guys. We tell them, yes, you are a cardiologist, but that's what you need.
No, actually, that was, what about a high-fat drink? Usually at Al-Mallah lab, they used to, just the day they used to come in and give a high-fat.
It's not completely enough for that. Some labs have used some of these just free like prolonged fasting, but our experience is if you really want to be sure that this uptake is not coming from the myocyte, you need to kind of limit the carbohydrate the day before. And then we ask them for prolonged fast, minimum 12 hours, but it should be longer. And then we go ahead, when they come to us, we do an FTG, we do a perfusion scan to see where the defect is. And then we give them heparin, because heparin promotes lipolysis, so it will increase your free fatty acid. So that's another way to promote that. And then, but this is not very common. Not every hospital give heparin. And then we give the FDG, wait for 60 minutes, and then image the patient. So the reason I'm going through the technicalities, because the fellows, sometimes I got a request from the floor at 4 p.m., can we do sarcoid scan? Like, is the patient prepared? Like, this is not a test you order from the ED and we do it like within 30 minutes. This is a test that requires 24, 48-hour preparation before we do that, because we want to make sure that we're picking it up correctly. So this is how a normal scan looks like. There is no FTG in the myocardium. You see the myocardium there, and all the FTG is in the blood pool. Yes, Victor? So we give heparin to everybody in our lab, and I find the images look much better if you give heparin. The only time I don't give heparin if the patient is already on anticoagulation, so I don't want to give them double anticoagulation. So we just give 5 units per kilogram for, 50 units per kilogram. So about 3,000 to 5,000 units for 15 minutes, and then we inject FDG. So we're giving it to everybody. It's a kind of, in the guidelines they said it's optional, but personally I like to give it because I find like it really, the image quality look much better when you give it. We're coming to that. Okay. All right. So now this is how a normal scan look like. So you kind of see it like a negative image, all the FTG in the myocardium and the blood pool, and there is nothing in the myocardium. Now this is how a abnormal study will look like. So in perfusion, which is the first row, or here, you see this perfusion defect. Now in this area of perfusion defect, now I see FTG uptake. So when I see that, I know that there is a perfusion defect, and it could be a scar, could be from edema, could be because there is active inflammation there. The perfusion tracer did not make it there. But then when I did the inflammation, I see a lot of inflammation in that area. So this pattern is the most accurate one for assessment of inflammation in the heart. So you can see a perfusion defect, and in the same area, a mirror image of it, of that area that's missing, you see FTG uptake there. And we can look at it in fusion. So in this case, for example, you see it in the septum, you see it in the lateral wall, you see it in the papillary muscle, and also you see it in this patient in the left atrium. But since we can cover the entire chest, you can see, like, for example, this patient had it like very aggressive inflammation in the lungs. We can also look at all these lymph nodes that Dr. Shah just showed you on MRI. And we can see the inflammation here. So we see uptake in the heart, but we also see uptake in these lymph nodes. That even makes us more concerned that this is active inflammation. So the typical protocol is that we want to see the normal study will be normal perfusion and no FTG uptake. Now, if you see normal perfusion and diffuse FTG uptake, that might indicate to you that the patient did not follow the diet. So how do we pick it up? With experience, you learn your tricks with that, but not everybody who's doing this have read hundreds of cases of these. So this is, for example, one patient that came to us, and we looked at it, and like no perfusion defect, maybe a tiny bit in the basal anterior wall. But then when I do the FTG, I see a lot of FTG uptake. That's way more than the defect I see. So we told the patient, and the patient says, yes, I followed diet. Obviously, all of them admit that they followed the instructions before we start. So if a patient tells us that they didn't follow the instructions, we're not going to even start with that, and we'll just reschedule them. But this patient, we didn't believe it, so we said, why don't you follow the instructions for 48 hours? Whatever they did, they came back later, and now it's a normal study. So it's very important. So we said, can we just keep it to the expertise of the reader, or is there a better way to kind of systemize this so when this goes to the community, at least we talk the same language? And this is work that Mouaz presented in the ASNC Young Investigator and just recently published, where we measured for a full year beta-hydroxybutyrate on everybody coming to us. So beta-hydroxybutyrate, so these are ketone bodies like you're in your DKA because the patient has prolonged fasting. We just went backward, blinded, and looked at these scans and correlated with whoever had good study versus whoever had failure. And we found what is the sweet spot. And what we found is a 0.4. So if you get beta-hydroxybutyrate of 0.4, all our patients were well suppressed. So now we're adopting it in our lab, and for you, for those in the group, you know now if you order it for an inpatient, we're not going to bring them to the PET lab until their beta-hydroxybutyrate is 0.4 or higher. If not, then they're going to be fasting longer until they cross that margin, because at that time we had zero poor preparation. Now, among the group, which is 0.2 to 0.4, it's almost a flip of a coin. And this is where we try to get more information on this. So we adopted such a protocol. We're not like turning away outpatients yet, but unless they admit that they didn't follow the diet, but we still get a lot of this. This week, just another paper came from the University of Michigan group, completely independent cohort, and they found this very similar threshold, 0.36. So we are like at least 2 independent cohorts showing very similar numbers. And what they suggested is either if it is 0.35 or different, then you can either proceed, but keep in mind that you may get a false positive and you need to have some expertise, or just go ahead and reschedule the patient. Now, if you're above 0.35, most likely what you see is accurate there. So it's kind of like more standardizing the field for this. So,
what's the lab turnaround time to get that test?
So it's about 2 hours for us. So by the time we do perfusion, so we're not holding patients for that. So for outpatients, we do it as they come, but we have that to guide us for the interpretation. But for inpatients, because this is where we had a lot of failures on these, so we're not bringing them to, so they order it at 5 a.m. By the time the test is like ready to be done at 8 a.m., we will have the results. And if it is less than 0.4, we're not getting them to the lab. They have to fast longer, and we recheck it at 11 a.m. And if it is crossing 0.4, then we can do it in the afternoon.
So I presume there's no point of care versus...
Not yet, but we are trying to investigate something like similar to the one that police check for the alcohol. So there is apparently a breath test for ketone, but how to correlate the numbers versus qualitative, that's something we're looking into potentially investigating there. But I'm not aware of a point of care like creatinine and other, but it will be very handy and nice for that.
What if the patient is a type 1 diabetic?
So for type 1 diabetic, we've done few cases with success. They are more challenging. We tell them to take half the dose of insulin the night before and come, and we try to do them the first case in the morning. Obviously, I don't want to push them to DKA. The other thing is, what do you do with vegetarians? So we have created a whole menu for vegetarians that want to eat no carbohydrate diet. So there is a full list of tofu. It's in the lab. If you want, we can get you that. These are the very common questions we get about these. Now, the biggest question that always comes, like when I see something, how sure I am that this is cardiac sarcoid? And let me tell you, if you've probably heard me, I intentionally didn't say sarcoid. I've been saying inflammation because FDG is really predicting inflammation, and we've had multiple cases from different etiologies for that. The question is, do we need a biopsy to make a diagnosis? I think inflammation in general can be from multiple conditions. You need some sort of way to make a diagnosis of what's a pathology. It could be SLE. So all the inflammatory cardiomyopathies that Dr. Shah just talked about can appear similar on FDG PET. So that's why you need to know what's a primary pathology here. And sometimes it may require multiple biopsies to do so. This is a case that Dr. Attilawi published when he was a fellow with us. And this patient had biopsies multiple times, and everything came back non-specific, until the patient was transplanted. And this is the slide from the transplant. You see the non-caseating granuloma. Multiple biopsies that were negative. And nobody gave him a diagnosis of sarcoid, but the FDG PET was very positive, and he was treated and improved, but improved overall until he got the transplant. When he got the transplant, you see that it was sarcoid. This is another case that Dr. Valderabeno did a PET-guided biopsy, and you see here in the PET there was FDG uptake in the LV, but we also noted FDG uptake in the interatrial septum. So he did 8 biopsies of the LV and 1 biopsy of the interatrial septum. The 8 biopsies of the LV were negative. The one with the atrial septum was positive for non-caseating granuloma. So sometimes you may need to be very innovative in making the diagnosis. Obviously, we tell them about any FDG uptake outside the heart. So biopsies like of lungs, lymph nodes, that might be also very helpful to make the diagnosis. But you will need some sort of tissue diagnosis to say that this is sarcoid or lupus or Wegener. All of these we've seen cases of active cardiac inflammation with. So for the sake of time, just to show you, there are some case reports that came up in the past year or so saying that obviously not every FDG uptake in the heart is sarcoid. There are some cases where you have very mild uptake, so the blood pool is not fully suppressed, but this is a case where there is like SUV of 2, so very kind of lowish uptake, and turned out to be amyloid. We have 2 cases like this also in our cohort that turned out to be amyloid. This just came out in JACC imaging earlier this month, where there were a few cases also had very mild uptake, and these turned out to be some genetic mutations, including one for hypertrophic cardiomyopathy. So there are some evidence of inflammation there. So you need to know what's a primary disease, whether from the heart or outside the heart, but not every FDG uptake, if done accurately, is cardiac sarcoid. It could be multiple of things. It's just cardiac inflammation. We know that similar to the prognostic data that you heard from Dr. Shah, there is we're starting to see some growing evidence from PET that the more FDG uptake you see, the worse it is. And we also did a meta-analysis of that, and now we even have data for all-cause mortality and MACE, but we also have data even if you see RV uptake, that's also prognostic, and this is work that Ahmed published a couple years ago. So the final thing where PET is extremely helpful compared to other modalities is really to look at follow-up. But before that, I just like to make this comment. I see a lot of meta-analysis coming out, accuracy of this versus this, CMR versus PET modality for detection of sarcoid. And this is not, I think, the right way to look at it, because PET is going to come after CMR and primarily is going to look for active inflammation. So you can have a scar without active inflammation. That's still going to be positive by MRI, but could be negative by PET. So what we are looking here is more of a complementary. So a negative PET doesn't mean that the patient does not have sarcoid. They could have had sarcoid. They could have had a scar, but the scar is not actively inflamed. Even if they had VT, the VT could be scar-mediated rather than non-scar-mediated. So the final thing is that we do these studies on many patients with multiple times because we want to, this is where the sweet spot for PET, that we follow the inflammation. So this is one case where you see there is inflammation in the basal septum, and it's completely gone on therapy. And we also can follow up the extent of the inflammation and how bad it is, the intensity of it. And we can also, within our field of view, look at the extent of extracardiac inflammation. So you see all these lymph nodes that are positive, they definitely have decreased in terms of amount. So obviously, mission not accomplished yet, but at least we're heading in the right direction. Again, this is not limited to myocardium because FTG is very nonspecific. So this is a case, for example, with pericarditis, and you can see this. And we were looking for myocardium, and we see this uptake in the pericardium. You can see it here also. This is the CT. And you can see there is thickened pericardium on the CT and significant FTG uptake in that territory. We can also do it for aortitis. So this is a patient where the patient had significant aortitis, and this has been on and off, and can be used also to look for titration of therapy. And when we do fusion imaging, you can see this area is the hottest area. The areas that are calcified are the least inflamed here. So let me quickly switch off to amyloid, and just again, for amyloid, we come after a good echo or a good CMR that the patient should have a clinical suspicion for this and imaging supporting it. Now the role of PYP imaging, which is done by SPECT, not by PET, is really to differentiate the different types. So we're not making the diagnosis. A patient could still have amyloid and have a negative PYP. So we are coming after you have done a great echo. You have your typical strain pattern, typical wall thickness, or typical LGE pattern on MRI, and now you want to know, is this patient going to go for chemotherapy, or is this patient I'm going to put them on tafamidis? And this is where PYP imaging comes to make that distinction. If you see PYP uptake, then you will say this is uptake. This is ATTR amyloid. So the first thing is how this field started. I just want to give you some cohort because we're making some shifts and changes to this. So this all started with planar imaging. Think of planar imaging like chest X-ray. So people were just doing chest X-rays, and here you see a lot of uptake. Here you see no uptake, and they graded them as grade 0 no uptake, grade 1, grade 2, and 3. We compare the uptake to the ribs. So if the cardiac uptake equal the ribs, that's grade 2 and grade 3. And now the more grade 2 and 3 are still labeled as positive, grade 0 and 1 are negative. Now there is a lot of interest in grade 1 because some of them may potentially develop, like later on progress to grade 2. But the point here is that what we found is that if we're just going to go with this planar imaging, then there are some challenges with that. And the main challenges is you may get false positives. So although the accuracy data has been kind of pretty good in a sense that when you take selective populations and like compared to biopsy in the right highly tested, highly suspected population, you end up with high accuracy in terms of 92 and 95%. But this is not a screening test for the population. So it's not like you see a patient with heart failure in your clinic or just like feeling a little bit of symptoms and then you order a PYP and you're going to get like this kind of accuracy if you just lower your pretest likelihood. So we are right now moving from just planar imaging, which is like your chest X-ray equivalent, to SPECT imaging. So think of it like a CT. So everybody is going to get a SPECT imaging, and then we reconstruct the heart because we want to make sure that this uptake is coming from the heart. Because there are some cases where there is a lot of uptake in the myocardium, and that uptake is only in the blood pool, not in the myocardium, and it might give you a similar picture on the planar images. So SPECT is going to have a lot of utility, and now we're actually discouraging people just to rely on planar imaging or completely even drop planar imaging and mainly focus on doing SPECT imaging and look at it qualitative and maybe quantitatively. And we've even taken it a little bit more, so we do it only with SPECT CT, so we can localize where the uptake, like here, for example, I see the uptake in the septum, a little bit in the lateral wall. And some of the reason for that is that there are challenges with planar imaging. Here's a patient that I see a lot of uptake in the heart, and I do the ratio, it's 1.5, so I'm concerned that this is cardiac amyloid. But when I look at the 3 hours, the SPECT CT image, there is no uptake in the myocardium. The myocardium is free of uptake. All the uptake is in the blood pool. So it's kind of like deceiving, especially in these patients with very low cardiac output, low ejection fraction. This is similar when we image the patient at 3 hours even. So you wait a little bit, you hope it will clear up. You still have a high 1.3 ratio, but still, again, there is no cardiac uptake. It's just in the blood pool. This is where the septum will be, and this was the lateral wall. So no myocardial uptake like what we saw in the other studies. So there are multiple reasons. If you're just going to rely on the ratio and planar images, there's a long list of false positives and false negatives. And that's why we are pushing folks not to do just planar imaging, but to do SPECT on everyone.
You have to order it differently?
No. In our lab, for the past 3 years, no more PY. I mean, we told the lab we're doing only, but I'm talking for hopefully someone listening on YouTube or something, because in the community, the most common is still being done planar imaging, and without PYP, we've seen many cases, without SPECT imaging, we've seen many cases where there were like false calling or false positives. So just for you also, if you go outside, there was earlier this year a shortage of PYP, believe it or not. The supply chain made it there. So PYP is the primary agent used in the US. In Europe, they use HMDP. So when this happened, we quickly jumped in and put in an information statement. I've never done an HMDP scan. But many of my colleagues, like here, we're lucky we never had that shortage, but on the East Coast, they had a lot of shortages. So they look exactly the same as PYP. So if you go in practice or your site doesn't have PYP, there is HMDP available. And you can look at it, same thing with SPECT imaging. The only difference, and this is the case from Yale, where they did actually PYP, and on the same patient had an HMDP scan, and it kind of looks very similar in terms of uptake. So accuracy-wise, it's also very similar. The only thing is that with HMDP, you're going to do 3 hours. With PYP, you can do 1 hour or 3 hour or both. So you have to inject, wait 3 hours before you image the patient with HMDP. And finally, a common question that keeps coming, shall we do follow-up PYP? I had PYP on the patient. I put them on tafamidis. What shall I do? Can we repeat the PYP and see if it is better? Unfortunately, as of this day and age, we don't have a tool to follow-up response. There is a lot of hope for PET tracers that are currently being studied to look for that. And these PET tracers may change with time. And we'll soon start a trial here with using one of these tracers that could potentially be used to assess for therapy and tell you, like similar to FDG in PET, it's an FT18 agent, and it has good response also and good data. At least the data is currently being gathered to look at potential response to therapy. So with this, I just want to emphasize one concept that I've already mentioned. So for PYP, when you order it, you should already start order it in the right population. So it's not just like patient had an episode of acute heart failure, I want to order a PYP. Heart failure with typical echo and or CMR, you have already ruled out AL by doing your serum kappa and lambda, and also then you do the PYP. If the PYP is positive, then you have a diagnosis of ATTR, and then you can go for genetic to check if it is a genetic, the wild type or the genetic mutation. So to sum it up, always screen for AL and always perform SPECT. So for those of us, we are here doing that. Now, we're not requesting, there have been few case reports where the patients had concomitant AL and ATTR, but these are like really rare cases, but it is very important to screen for these. So before you order the PYP, please go ahead and make sure that you're not dealing with AL amyloidosis, and then order a PYP, and on our job, we'll make sure that we do SPECT imaging to confirm that this is not a falsely positive study. With this, thank you very much. Any questions? Yes.
So my question is, with a good quality echo and a high clinical suspicion for amyloid, is there room for ATTR specifically, is there room to just go to PYP without MRI?
So, I mean, MRI is going to, first of all, confirm your diagnosis. So it very much depends on your, like, how that's, I think the ECV data is very helpful in MRI. So confirming it before subjecting the patient to a $200K therapy per year with all its complications, it's very reasonable. I know some sites are not doing it, so it's not kind of a must. If you're very happy with your echo and you're fine, I mean, I don't think the insurance will request it, but I think if it was me, I want to make sure that there is enough data from the LGE, from the ECV, and now there is some data starting to suggest that ECV can be used for follow-up of these patients. So that might be an additional value for MRI in this, but Dipan, if you want to.
Yeah, no, I mean, I think yeah, I think that the key thing with all of these cardiomyopathies is, you know, compared to all of the scenarios where we do lots and lots of testing, the cardiomyopathies are a high-risk patient population. And so that's a group of patients where my threshold is say, okay, if I want to get some additional tests to confirm the diagnosis, to confirm my specificity of my findings, makes sense. I think one of the things we know is that with the MRI, the LGE imaging that you get, it has a very high specificity of its findings. But I think more importantly is not just in the cases where you've made a diagnosis of amyloid, but what about the cases where your diagnosis of amyloid is excluded, right? Oftentimes you can find other diagnoses based on the MRI patterns that can help you. So I think, remember, you know, even though now, I think with a lot of the education around, you know, therapy for ATTR amyloid, there's a focus on that. But keep in mind, all the patients that you think about that have increased wall thickness don't necessarily turn out to have amyloid. They may have some other cardiomyopathy. And so, you know, I think one of the things we don't want to do is say, okay, we've done a PYP scan and it's negative and we just stop, right? Because ultimately, again, if it's a patient with a cardiomyopathy, you want to try to get as much information as you can. And I think that's where probably the MRI also helps, is in alternative diagnoses.
Yes.
How sensitive is PYP detecting early stage amyloid?
I think the lower you go on the grading, the lower your accuracy is going to be, but I know that there is a lot of push to kind of predict it earlier because this is a time where you could make, but you're going to be testing a lot of patients to find one that's real. So I would still like look at the overall clinical picture. So if you have like really a grade 1, but then you have to look at the overall clinical picture. Look at like if the patient has bilateral carpal tunnel or has genetic mutation. This is like the genetic mutation group is where people have suggested that it might make sense to follow these grade 1s. So if you know that the patient is prone to develop it, and now you start to see some uptake, and you've done a good quality scan, then you know that the process have started. But again, you have to look at the overall, the MRI, the echo, the clinical picture, the overall symptoms, and then you're not going to just rely on one data point and make a clinical management decision. And biopsy is always there for that. And we've had, I think, 2 or 3 cases where they were grade 1s and turned out to be positive by biopsy. So biopsy is like, we do less of biopsy and we should do more of these, because you could be surprised, it could be something else completely.
Yeah, I mean, I would echo that. I think that ultimately getting a tissue diagnosis is very, very useful. Because again, when you're talking about very expensive therapies, you'd hate to treat a patient who doesn't really need this therapy because he doesn't really have this diagnosis, because we came up with this diagnosis based on some imaging findings. But so the more confirmation you get histologically, the better. Now, obviously, the thing is when you sit down with a pathologist, the same way as we who do a lot of imaging recognize, the more you know, oftentimes the more uncertainty you develop. In the pathology world also, things are not so black and white either. So I think right, so you got to put on your clinician hat and put everything together. But I think the more piece of information you can get, the better, especially for a high-risk patient population like a cardiomyopathy group.
What does PYP or FPG or LGE uptake in the left atrium with them? Like, what kind of risk
So FTG in the left atrium has not been well studied, but on few cases, anecdotes, we've seen that whenever there is LGE in the FTG uptake in the left atrium, patients tended to have more atrial fibrillation and atrial arrhythmia burden. So for the left atrial PYP uptake, there is a paper from the Cleveland Clinic group published last year in the circulation imaging. They showed that it correlated with atrial fibrillation. It was like more prevalent. So we have a paper right now in review that Jean-Michel Sad did that, and what we saw that it was PYP uptake of left atrial in the left atrium correlated with not only prevalent but also incident atrial fibrillation, even if the LV PYP was negative. So that might be a little bit more. The nice thing about the Cleveland Clinic paper is that they had few histologic cases that on those, like I think they have 1 or 2 patients that went for biopsy, and these cases turned out to be amyloid uptake in the left atrium. And when I was in fellow, we published a paper also, LGE in the left atrium was very specific for amyloid compared to hypertrophic cardiomyopathy and others. So I think the left atria, we don't look at it. It's not as easy when we are looking at it in imaging, but I think this is a big room to look for atrial arrhythmias and others, especially when you put ICDs and these patients come back later with inappropriate shocks from atrial arrhythmias. All right, thank you.